Professor Emeritus of Ophthalmology and Director of Oculoplastic and Orbital Surgery at the Children's Hospital of Philadelphia at the Center of Human Appearance at the University of Pennsylvania, Paramount School of Medicine. Articles and chapters, and edited several books on oculoplastic subjects, including the first major textbook of pediatric oculoplastic surgery, which has recently. Among numerous leadership positions, Dr. Katowitz has served as president of the American Society of Ophthalmic Plastic and Reconstructive Surgery, and received an Organizational Leadership Award from his society, as well as the Wendell Hughes Leadership Award given jointly in the American Academy of Ophthalmology. He also received the Marshall Parks Honorary Lecture Award given jointly by the American Society of Pediatric Ophthalmology, Strabismus, and the AAO. It's a pleasure to meet you in the morning, Dr. Katowitz. It really is a great lecture in the morning. I hope this lecture is good for us. Thank you, Dr. Katowitz. Come with us.
Thank you so much. It's an honor to be here in your beautiful city with such wonderful new friends. My wife and I have enjoyed just sharing a couple of days here. We're overwhelmed by your generosity and the warmth of your personalities. It's a wonderful Peruvian culture that we're being introduced to. So thank you so much. So. We'll now begin this lecture, and we'll hopefully have some time for questions, which I hopefully could answer. So, so I don't have any. But this is a really interesting subject because we, as ophthalmologists, as surgeons, particularly in oculoplastics, are I don't need the light. Oh, you want it. We're dedicated really to trying to improve both function and appearance. But the problem is really in trying to achieve a satisfactory balance. So it's important for us to think about definitions. So what do we mean by appearance? It's really more subjective than objective. And one of our Supreme Court justices on the federal bench, they were dealing with pornography issues and trying to figure out a definition of pornography. And this learned scholar said, I don't know how to define it, but I know it when I see it. And that's kind of how we think about appearance in many respects, because we generally say, does it look better or look worse, when we think about appearance. But function is somewhat different because it's a little bit more specific, more objective, and it usually applies for us to an organ system. Does it do what it's supposed to do? Does an eye see? Do the lids blink? Do the tear system, does it drain properly? But in my opinion, I think we really need to be looking at function in a much broader way, because we should think about how emotional well-being or a sense of self impacts on how we function with our family, peers, teachers, employers, basically our ability to function in society. So by this definition, I think appearance may assume an equal or sometimes even a greater importance than function. An example is like frontalis suspension. Well, we know when you do that ptosis repair, the patient often has lack of thalamus, exposure issues, poor blink, and yet the appearance is accepted as more important than the function of blinking normally. There are also some ethical considerations. Basically, what is really achievable with surgery? Does the patient have the capacity to appreciate a change in appearance? And is the purpose to primarily benefit the patient, in pediatrics the child, or the family who's pushing for something which may not even be that necessary? There are descriptive categories for us to think about function. One is pathologic, because we can classify disease entities. But I think for us in surgery, an anatomic topographic approach has a better application for thinking about surgical procedures. So in terms of our oculoplastic efforts, we really could divide this topically or anatomically into three areas: the periorbit, considerations about the eye itself, ocular considerations, and then the orbit. And of course, we could spend weeks on any one of these subjects. The periorbit, you're aware of all these things, the ocular considerations, and the things that are listed here. But in terms of talking this evening, I thought I would just pick a few examples within these categories. So first, the first category of the periorbit, specifically the eyelids, we'll talk about colobomas from congenital, post-tumor excision, trauma, and let's look at some examples of this. So congenital lid colobomas is certainly an interesting subject. It's important to make a distinction between a true coloboma, which is a defect of all layers of the lid, of the lid margin, and a pseudocoloboma, which is a term that I like to use for the kind of lateral droop in the lower lid, which doesn't necessarily have any marginal component to it, although in some of the craniofacial conditions of the Tessier 6, 7, and 8 clefts, there can be a defect. So in this coloboma management, as seen here, we try to temporize as much as possible, and you really can do this with lubricants and so forth. Plastic wrap is very useful, but it's also very dangerous in an infant, particularly, because they could easily get loose and it could smother a child in terms of their breathing, so you have to be very careful with that. And we used to think, oh boy, we need to do this very quickly, but you actually can defer this to 6 to 18 months of age, as long as the cornea is tolerating the exposure. And in children, particularly in the amblyogenic period of time, we really try to avoid lid sharing, because if you close the lid for weeks, you're going to get an amblyopia situation. So our main effort is horizontal closure, where we excise the edges to create a wound that can heal and preserve as much normal tissue as possible, and then close the wound like a vertical lid laceration. So there's also something that is an interesting suture called the near, far, far, near suture that Byron Smith, who was one of our godfathers in oculoplastic surgery, taught us. And that is a kind of a mattress suture that really, as you can see here, what that really means is you're coming near through here, then far, then back far, and then coming out here near. And that takes a tremendous amount of tension support. So in this particular case, you see that we were able to put that together and it held pretty well, but there's ptosis there and it's not perfect. And so this brings up an interesting question. So we have an improvement. Certainly there's a functional improvement, but appearance-wise it's not that good because there's ptosis there. So one of the things that became obvious to me, well, it only took me years and years to become obvious, but the idea is why don't we advance the levator while we're repairing the coloboma? And I think that's really critical. So here's an example of a baby with Goldenhar syndrome and associated coloboma. 1 week old child, also had a lipodermoid, as you can see here, right there, that lipodermoid, which is part of the constellation in Goldenhar's, and the preauricular appendages, and there's usually other mandibular or vertebral issues. But here we went ahead and did that kind of closure as I described, but the main thing I'm stressing here is advance the levator muscle. I mean, you can't hurt anything, because once you're pulling that defect together, it's going to tether the lid and make it lower automatically, like we showed you in that other case. So if we find the portion of levator muscle that's there, that's there laterally, if you look here, I mean, there's going to be a muscle in here, and you can just find that and stretch it over to the other side and make that work. So here's the child at 1 week. And then at age 6 months, 2 weeks post-op, that kind of closure with the levator advancement done at the same time. And here he was at 9 months of age. So we have pretty good balance between function and appearance, and it's a good idea to advance that levator muscle. So there are problems when you have a defect that's greater than half the lid, because you can't always pull things together horizontally. And the two main things that have been described are the rotating Mastardi lower lid flap and the Cutler-Beard sliding flap. But both of those are going to include the visual axis. They're not always so useful in a child. But this is just a demonstration of Mastardi's rotating flap. And as I said, better to go with the sliding flap for the amblyogenic situation. Here's an example, though, where we could get away with that because, unfortunately, this was really a tragic situation. A child was born with a big coloboma like this, and normally, we would lubricate it. And unfortunately, in another hospital, the staff decided that they would protect the eye by putting a tape over that. Well, of course, it created a corneal ulcer. And then the child developed glaucoma from that and eventually really lost the eye. But at the time, we first knew there was never going to be good vision there, so we went ahead and did a rotating Mastardi flap like this. One of the advantages, supposedly, of the Mastardi flap is that you are moving lashes from the lower lid to the upper lid. Much of the time, those lashes get lost anyway. We were lucky in this one, and I've had a couple of other cases where the lashes did stay and look good, and that's an advantage of that particular kind of flap. The Cutler-Beard sliding flap is more commonly used for dull tumors such as this, a basal cell carcinoma, and whether it's a Mohs resection or frozen section control, you wind up with a pretty large defect, and that would be pretty hard to close horizontally. And so in this situation, the Cutler-Beard flap is a bridge flap which you mobilize vertically, and you have to leave 4 to 5 millimeters of lid to have a viable blood supply. And then you can slide that underneath and leave that for several weeks, usually 4 to 6 weeks to really have good healing. And then you can separate it and debulk and so forth and adjust the lid. So we get a pretty good result here, function and appearance, but there are surgical concerns because you can lose the lid margin if you don't protect that blood supply. You're occluding the visual axis. The flap is thicker, and we still have a little bit of lid retraction here, but he's perfectly happy and doesn't want anything done. So here's a situation. This morning we saw a case of partial cryptophthalmos, sort of like this, in a child at the Children's Hospital this morning. Here's a situation where this child has a coloboma, but sorry, let me go back here. If you see here, the lid is fused to the cornea, once you're pulling that apart. So he's got a coloboma here. He actually has a microphthalmic eye with a cyst. You see that bluish area here? And this lid skin is stuck to the cornea, and there's not much of a cul-de-sac up above. So this is a challenge. What are we going to do here? And on the right side was a little bit easier because we could dissect that off the cornea and mobilize enough conjunctiva to have reasonable fornix. And so we did get a reasonable repair on the right side. On the left side, we had this cyst as well as over the microphthalmic eye. Now, you could look at that and say, well, why don't we take that out? But the truth of the matter is that it's providing volume. You've got a microphthalmic eye, but you have a cyst on top of it, and that's good because it's making more volume, which is going to stimulate orbital bony growth as well as some soft tissue growth. I don't really care most of the time in microphthalmia, anophthalmia about the bony orbit because that's not what people see. They see the eyelids, and can they wear a prosthetic shell? That's what people see. That's what the family sees. And this is a situation where we could allow the increased volume to work for us and do something about it later. But in the meantime, I tried to repair this in the horizontal fashion like we did the other side and the other case I showed you, but it really didn't work so well because we had a defect like this right here. And so that was not very successful. So then what to do? So in this instance, again, we didn't have a situation where we're going to have very good chance for vision, so we didn't have to worry about that. So I thought, well, why don't we try a Cutler-Beard flap? At the same time, I put in some mucous membrane graft and made a scleral shell that we could anchor to the arcus marginalis periosteum around the orbit, and that way we were keeping something in to help the fornix stay in place with the graft that we had put in it. And after 5 months, we opened that up and took the shell out, and then it was a question of trying to bring this lid, which was way out of place, into a normal position of 20 millimeters on each side. And at that point in time, that's when we decided to mobilize these tissues in a different way. So here he was at age almost 2 years, able to wear a shell, but it still doesn't look as good as we'd like it to look. And here he was after some more work when he was 8 years old. But his vision was great on the right side, even though we shaved that, did a keratectomy to shave that off. So he's pretty happy. His brother, this is his brother standing up here. His brother had a more complicated problem. These kids were living in Hong Kong. Their father worked for an insurance company there. And I got a call that they were sending somebody to Philadelphia for a corneal transplant. So, you know, when the kid arrives, he looked like this. And I'm looking, this child does not need a corneal transplant. I mean, I don't know where that came from. And that's how his right side was, even worse than his brother. They have a normal sister who looks pretty, you know, no problems at all. The other interesting factor here is that the father, working for an insurance company, their insurance was so bad it was about was about 10,000 soles for everything. For the insurance company where his father's working, well, after a lot of arguing, they finally decided they were ashamed of themselves, so they would cover this. And so what we did, we had some other problems here because from a pediatric ophthalmology standpoint, his medial rectus muscle had no Tenon's capsule. Everything was crazy. The motility was bad. He had a bit of a corneal scar from the lid skin over there. So we didn't have a lot of hope for an amblyogenic success. And because of that, given the situation, I decided to cover the cornea with a mucous membrane. We'll talk about that a little bit later, and do another ptosis repair. And so, whoops, wrong case. So I'll go back to this one here. You know, he looked pretty good. The funny thing was, he also had a blue shell, perfectly blue. He liked to wear that. He would go to parties with this with the blue shell. Then he decided to go to college and apply to medical school. He went back to the regular prosthesis. But they're a wonderful family, and the kids are doing well. But it just shows you the different approaches. And as we talked earlier today and earlier this evening together, in oculoplastics, a lot of what we do is very artistic. You know, there's a lot of intuitive, abstract thinking. And as I was saying earlier, sometimes I would go to the operating room and the nurses would say, "What are you going to do today?" And I'd say, "I don't know." You know, and that's really the truth, because until you get in there and start moving tissues around, and even when you have a game plan, sometimes you have to change that game plan depending upon what you're seeing and how things move. And that is one of the, I think, enjoyable challenges that keep us happy in the work that we do, and maybe drew us to it to start with. So let's move on again. So this is another coloboma. This is a lower lid coloboma. And this is a very instructive situation because I think it's really critical, although we have very good multidisciplinary teams, you work together, but you have to decide who does what when. So in a situation like this, our chances, we basically had this big coloboma. We had adhesions to the cornea. The eye was not, this was not going to be a seeing eye either. And I think we have to, even though I trained in cornea, we have to sometimes decide, you know what, that's not what this child needs. You know, we can't always save the vision, although that's our primary goal. But it's also important, again, to think about appearance, because that's going to have a major effect on a child's life, or on an adult's life for that matter. So here we had a situation where I'm working with my colleague from plastic surgery, craniofacial surgery, Oksana, and we decided, you know, who was going to go where with what flaps. Well, the cleft lip was a bigger deal because in terms of feeding, this child can't feed normally. That's more important than trying to worry about the eye, which isn't going to see anyway. So she mapped out what flaps she wanted to use to reconstruct the lip. And then I had a chance to decide what we might be able to do. So she worked on her flaps, and then once we got that together, I had a chance to create a Mastardi rotating flap because we could then play that game and create a lower lid. And this was her on the operating room table the next day. And here she was 6 months post-op. And then here she was 10 months post-op. So again, you know, we don't have any functions, so on our balance it's not so good on the scale. Appearance is a lot better. It's not perfect, but certainly it's a lot better than what we're starting with. And this child at least looks relatively normal. Here's another kind of a situation. This is in the Tessier clock face system. This is a number 4 amniotic band cleft. I don't have pictures of this in here now, but amniotic bands can form. They used to say that amniocentesis could help to form that, and it's one of the problems. We don't do that very much anymore because the genetic studies can be done through blood rather than going in to disturb the amniotic area. But when these bands form, they can wrap around your hands and cause amputations. They can wrap around the face, and they can be swallowed. And that's what happens in a situation like this. The band is swallowed, and there's a pressure necrosis creating that cleft. So in this situation, trying to repair this, we decided we needed to get tissue. We did a mid-forehead flap to come down, and then that has to be debulked. And you can see he had tears here, but we were able to put a Jones Pyrex tube in, which he's lived with very well. And so basically not perfect function or appearance, but pretty even in the result. So getting back to the cryptophthalmos, and Fernando and I were talking about this earlier, you know, what do you do with a case like this? And it's very hard for us. I think we're all sort of, we go into medicine, and especially in surgery, not that we're supermen and superwomen, but we kind of think we got to be able to fix this somehow. Unfortunately, there are things you can't really fix, and I think that's hard for us to accept. And that's important for us to make a good judgment as to whether something's worthwhile or not worthwhile, but you don't always know that. This is a really strange situation. So obviously, you know, you're looking at something, and this is a pretty horrible thing, a person with no face. It's a very scary thing to nursing staff, you know, the people in a nursing home. But this was very difficult. So we got imaging, the brain looked okay, there were eyes there. He did respond when we flashed the light. We got a VEP, electrophysiology. It looked like there was some kind of response, so we thought, gee, we really should make an effort to do something. So this is the kind of question that we need to ask for cases like this. We have to recognize the limitations for surgery, basically what is really achievable, and does the patient have the capacity to appreciate their appearance? And then another balance issue is the surgery for the patient, or is it for their family, you know, who may be pushing you to do something when maybe you shouldn't? So in this situation, you know, you need to decide what you can't do, and obviously one is you're not going to create normally functioning lids that are going to blink. You can't create glands to make tears if they're not there, and create a normal lash line. You know, we've tried all kinds of implantations and they look terrible, you know, so that's not a good way. In this situation, because of all what I told you, we thought we had some potential for vision, and we wanted to take a stab at it, literally. So I had a donor eye, and decided to do a tectonic graft, doing a sclerocorneal graft. Especially in a child, you have to have a Feringa ring because the whole sclera will collapse as soon as you open the eye. It's not as rigid as an adult, but sometimes even there you need it, but especially pediatric-wise. So the Feringa ring is sewed in place. We take a sclerocorneal graft, put that in, fill the chamber. There was no iris. The retina looked funny, more like a tapetum lucidum, like a dog, with a greenish tinge. So then I tried to create eyelids. I took some sclera left over, create that. And, this really, on the left side, looked not so bad, be heroes. Unfortunately, there wasn't any conjunctiva or Tenon's capsule. It looked like it to me when I opened it up. That wasn't there. And so we wound up getting scarring, and we had gone for the other side. At least we had a face. So, one thing was that even though, the staff in the nursing home where the child was living, weren't frightened of dealing with this child. And we've seen that happen in other cases where I've had a report that when a child or a person looked better, people, even though they might be blind, the way people interacted with them is very different if they look more normal than terrible. So this was a situation where, you're saying like, well, why did we do this? But so we did have that appearance improved the way I told you, but we got fooled because even though the MRI scan looked okay, the child wound up not having good mental capacity and didn't have a family involvement in the child's care at all. And so that was very frustrating. So this is one of these situations where we try to balance out doing good, and in retrospect, you wonder, should we have put this child through all this? And that's a conundrum. So let's move, what I'm saying here, again, did we benefit? I think it was frustrating. So moving on now to the eye in terms of function and appearance. Obviously, there are a whole bunch of things that we could talk about, we'll spend a week on each one of these subjects, but I thought I would just spend time on mucous membrane cover grafts, which I alluded to before. And we can do that for all of these things that are here, and I'll show you some examples. In congenital microphthalmia, we were talking about this earlier, you can at least try, this happened to be the son of a genetics fellow at the university. It's strange how sometimes things happen in children of people in the field in which they're the fellow, and that was the case for this genetics fellow, having a genetic abnormality in his child. But although there was a small eye with a cornea there, we always try first a clear shell, because if they can tolerate a clear shell, that tells you that they could tolerate a prosthesis. But so we go to the ocularists and say, try a shell, and they'll put something in for a couple of hours, and then we gradually build up some time, make sure their cornea tolerates it. And this was a case where indeed the child could tolerate the shell, and over time they would increase the size, and he could wear a prosthesis and look pretty good. And that was no surgery, just using the shell. Unfortunately, more frequently, when there's a cornea, even though small, they can't tolerate a shell. And if they're not going to have a chance for decent vision in a microphthalmic eye, then we will go ahead and take a mucous membrane graft from the lip. And it really can do two things. It does provide corneal protection, but it allows them to then wear a shell 24 hours a day. And if you're trying to stimulate growth of the eyelids so that they can look more normal and tolerate a normal size prosthesis to have symmetry, that's a big deal. So this is just an example of this child who had his cleft lip repaired, which you can see. And we basically harvest the graft from the lip, and you have to be really careful not to puncture even a pinhole, because once you suture this on the cornea, that will spread and you'll have some exposure. Now, as long as there's an elevation, they'll usually tolerate it anyway, and that allows them to, we put this on and we put a mattress stitch in between the rectus muscles and then some interrupteds around that. And so he's able to wear a shell 24 hours a day, and be a very happy, better adjusted child because he looks relatively normal. Let's move on to another kind of a case with motility restriction. So here's a situation of congenital orbital fibrosis, which basically is a situation where the extraocular muscles are frozen almost. They're tight, and you don't have much motility or any at all. And that means that if you have ptosis associated with it and you elevate that, the risk of exposure is going to be pretty serious. So here was a situation where we had the ptosis, we had enophthalmos that was pretty severe, and our craniofacial team looked at this and they said, you know, maybe what we could do is we could repair the enophthalmos and the eye would push forward and then the lid might be up higher and that would be good. Unfortunately, they went ahead and did the grafts. They took, in a child, you can split the cranium into, and you can actually take a chunk of bone out and it will reform, you know, below 18 months or so. After that, they get 2 layers and you have to take the top layer. It's different. But they took bone grafts and they put them in to push the eye forward, but it didn't do what everyone hoped it would do. So the ptosis was still there. We patched this child, tried as hard as we could to get vision, and there was just no hope of anything. So we knew we had amblyopia, that was going to be a problem. And you know, this chick, she was a pretty young child at this point in time, but she doesn't feel very good because she looks weird. Her friends are saying things to her. And so we decided, okay, let's use the mucous membrane graft and do a ptosis repair, because then we don't have to worry about exposure. And then she could wear a prosthetic shell. And she was much happier as a child. We were sacrificing the potential for vision. The one thing that's there is you can always take that mucous membrane graft off. It doesn't stick to the cornea. You could take it off, and also light's coming through. So if you have a light perception eye, it doesn't matter anyway if you're using your other eye. But that's one of the advantages. So pretty good psychosocial benefit. Here's an adult with a situation. This man was a psychologist. He also was a choir director at his church. And he was in an auto accident, and he suffered a retinal detachment, uretodialysis, aphakia, and so forth. He had lid retraction with lagophthalmos, and basically his life was a mess because he'd have to wear dark glasses to treat patients as a psychologist. With the dark glasses on, he couldn't see the score for play the organ. So his life was really being compromised. So we decided, okay, let's put the cover graft on the cornea and do a little lid surgery. And so he was able to wear a shell, and then he didn't need the dark glasses, and that changed his life in terms of his psychosocial benefit and welfare. So, okay, so from this standpoint, we've got good appearance, bad function, but he started off with that, so we'll accept that. So let's move on now from the one ocular subject we talked about to the orbit. And I just want to talk about a couple of things here. One is proptosis and NF1. So here's a really critical question. If you have a situation where your appearance is terrible, but you can see, are you ever justified to remove the eye in order to benefit your appearance? That's a pretty tough one, especially for us as ophthalmologists. So here was a child that I first saw. This is what he looked like in his first months of life, developing, as you can see, developing these tumors, plexiform neurofibromas in his lid and orbit. And, I thought, okay, we can fix this. So we go that, and I lift the lid up, and he looks great. Isn't that nice? Okay, 4 months post-op here at 18 months. But here's the problem. With NF, it's not that it recurs. That's a misnomer. It's just that you didn't get all the nerves that have a sheath that's going to have tumor. And so they keep growing and growing and growing, and they slow down and usually in your 20s, but sometimes they can keep going. I had one patient who in his 60s developed more neurofibromas all over his face. But here's a situation where what's happening? We've got more tumor growth. This is what's in his orbit. And just like we have the opposite of microphthalmia, or a nucleation if you don't have an implant, the orbit's small. Well, when you have a tumor, it's stimulating both from volume and from more heat, I suspect, to create this deformity, okay? And so how many times can we repair this? And this is what happened. It's 8 years old, and that's the proptosis, complete ptosis, tumors all over here. You can see other things, and this was a real tough situation. So I went, we had our own tumor board meeting at the Shea Eye Institute with all our different specialties, retina, everybody else, and the parents wanted to have the eye removed and for him to be reconstructed. But before I went ahead and did that, I sat and talked with our whole team, and everybody agreed, yeah, go ahead. So then I had permission to take an eye, which basically, at that point in time, I think he had maybe 20/70 vision, 6/15, 6/18, which is not bad, but he looked like a monster. So that's a question, that was what we were dealing with. So we went ahead and with a combined approach, as you saw from the craniofacial approach, and here he was at an older age, not perfect. He's older now. Oops, I'm sorry. He's older now. He's getting some tumor growth in his temporal area, but he's still, he looks like a person that's closer to normal than walking around like a monster. And so that was a situation of having to take a seeing eye in order to look better. So how about proptosis and orbital decompression in children? Well, is this acceptable in children to get in the orbit and do a decompression? Does it adversely affect orbital growth? And what are the reasons we might consider this? Well, we know it can be useful in thyroid, but there are other space-occupying lesions that I list here, and I'll show you some examples. But in thyroid, children are different than adults. Their proptosis is usually due to fat. It's not due to swelling of the muscles most of the time and scarring. So you often have very good motility. If you look at this child, you can see the degree of proptosis, but the muscles are not enlarged. They're also not scarred yet. So we have to balance out what's going on. Now here was a very pretty young lady, 12 years old, who had 26 millimeters of proptosis, getting some exposure issues, very unhappy with her appearance, obviously. And if you look at her scan, her medial rectus muscle had some enlargement, but everything else was not that much involved. She had stable thyroid studies, and we talked about doing a graded fat decompression, which we did through a lid crease incision, and so she looked pretty good with this. But taking fat out is different than going for bone in that pediatric age group, right? I mean, we didn't really know, so that's less aggressive. So we were going to ask the question, does bony decompression adversely affect orbital or facial growth? But I think it can be useful for a bunch of different things, and I'll just show you a couple of examples. This child was born and presented to us, I think she was a year and a half maybe, and she had this anterior bluish lesion right here, which looked like a hemangioma. At that point in time, Children's Hospital had one of the early CT scanners in the city of Philadelphia. We didn't have MR imaging at that point in time. So we did get a CT scan, and sure, we could see that lesion right there, but there was something else back here, independent. And okay, so we saw what it was. It was a hemangioma. We thought we could just follow this. It's not really hurting anything. But 4 years later, she got a spontaneous hemorrhage, and she had an afferent pupillary defect, and her optic nerve was swelling. She has a little ptosis there too, and the scan showed us what? So looking back here, that lesion that we saw earlier is now expanded, and it's pushing on the rectus muscle and on the optic nerve, and you got a little bit of scalloping of the ethmoid. So this was unresponsive to steroids, and we presumed it was a venous lymphatic malformation, which we would say today it's lymphangioma. And so we decided, okay, you know what? Let's do an endoscopic decompression, and we're not trying to go after the lymphatic malformation, but even if we could just get fat to prolapse out, we could take care of the proptosis and the pressure on the nerve. And so she did very well. The optic nerve pressure was relieved, pupil came back, color vision, mild optic atrophy. 5 years later, we got to see her, and she gained a good bit of weight, but she had no problems with hemorrhage or any other issues. So how about, here's another example, a foreign body reaction with proptosis. This is a child who was playing in his grandfather's house in the backyard, and he fell down, and they said that he fell on a piece of grass. Well, had to be something more than grass, because something perforated into his orbit. And on the scan, this was pretty scary, because there was something right in the cavernous sinus, and it's sitting right next to the carotid artery. So the neurosurgeons were not too thrilled with the idea of going after this thing, and so they said, well, let's just watch it. Unfortunately, what happened was he developed a fistula medially where the site of the wound was, and we thought, well, maybe we could drain this and find pieces of foreign body or something like that, and it would be okay. But we tried that, and it didn't work. And eventually, we had to go back. They agreed, and so the neurosurgeons took off the superior orbital rim and roof, and this is that's the frontal lobe, and that's a retractor, and there's the eye, and the surrounding periosteum is there. And so there is where the optic nerve is, and the sphenoid sinus. So, I was, sort of praying or whatever, and feeling something, and I opened up the periosteum in that area, and there was a piece of wood that we were able to get. And so we took that piece of wood out. Now I'm showing you this case for proptosis, okay, because we thought everything's great. We took that out. The trouble is that this proptosis persisted, and you can see that looking down from above. This is sticking out, and we couldn't understand why. I mean, there was no inflammation. There were no more foreign bodies. Everything looked fine in the orbit, but they were all unhappy with the proptosis. So we decided, okay, let's go ahead and do a regular bony decompression like we would for thyroid or whatever. And so, through a swinging flap, medial and floor, we're able to help them. So that was a decent result. Here's another situation, a congenital choristoma, which we tried to improve and give a scleral shell, and we put a mucous membrane graft on and repaired some of this. But unfortunately, because she had a normal sized eye, and you're putting mucous membrane on top of that, and then you're putting a shell on top of that, it created a proptotic effect. So they were all unhappy with that. And we had, again, no amblyopia situation. So in this situation, trying to go do a decompression, we wouldn't want to go through the conjunctiva because we've got a shell there. So I did a subciliary incision and some other work on the upper lid and did a decompression. And so she looked a lot better. She doesn't look very happy, but her proptosis was improved. So this is a really, really interesting situation. A bilateral microphthalmos with staphylomas. This was at 9 months. You could see the right side. And that was a blind eye. The left side, although it was microphthalmic, had light perception. And okay, so we decided let's nucleate the right side, put a dermis fat graft in, and he could wear a shell. And he looked, not too bad. But 18 months later, he started to have more development of the staphylomas. So it was getting larger. You can see the dermis fat graft on the right side looks great. That was fine. So we decided, what are we going to do? We got this thin cornea. How can we protect the eye from not perforating? So we thought, let's put a mucous membrane graft on and let him wear a shell, and that'll give him some protection. And so we did that, and he looked pretty good for a while. But then he started the staphylomas get bigger. So look at that right there. So now we've got this situation, and okay, I thought let's go ahead and we can't keep the prosthesis in. We could do a lateral cantipexy, maybe hold the prosthesis better, and that did pretty good for a long time. But by age 10, this staphyloma is really getting huge. I mean, look at this. So we've got this abnormal eye, but that staphyloma is about twice the size that it was. Okay. So I mean, I talked to all my anterior segment surgeons, and everybody agreed the same thing. Trying to do any kind of corneal surgery was probably going to risk losing the eye. And for him, he didn't care. His appearance was important to him on one sense, but seeing light was critical to him. He didn't want to lose that. And so we all decided, okay, what are we going to do now? So this was a situation where, again, he just didn't want to lose his light perception. And so, like I said, this was all too risky. So we thought, why don't we do a bony decompression and let the eye go back, and at least maybe we can buy time for this. And that's what we did. And so, he was back looking a lot more normal and hopefully protecting the staphyloma until something's going to happen eventually. But right now, that's the best we can do. So the last thing I want to talk about is exoneration in terms of balancing function and appearance. And essentially with an exoneration, we're often sacrificing functional vision for preservation of life or malignancy. And its appearance is also so important. And the question is, do we really need to sacrifice the lids and the socket the way we too frequently have to do? So I think the whole concept of a lid-sparing exoneration has been a misnomer, because it's not lid-sparing at all. You're saving the skin, to line that orbit. But, we're not sparing the lashes and the tarsus. So this is what we usually do for a supposed lid-sparing exoneration, and we're losing all those tissues. So I was trying to figure out how could we maybe save those structures in certain cases, and when might it be appropriate. So the idea was, if we could go into the cul-de-sac and save these tissues, and then just go strip the periosteum off the bone and take all that out, and then you could put a dermis fat graft in for volume, when might that work? And under what circumstances? So if you're planning radiation, one of the techniques that can be done, and one of my ex-fellows, Mike Kasem at Columbia University, thought of taking temporalis muscle, going through the lateral wall and lining the orbit to be able to put a graft on top of that. But I'm going to show you a couple of cases where I tried this technique, and I think it's been helpful. So this child was obviously born with a congenital anomaly. That's pretty frightening. This was at 3 months of age. She was at another very, very fine university, and a biopsy was performed, and the pathology was reported as composiform hemangioendothelioma. And they repeated that to get the same diagnosis, and they tried to treat with IV vincristine, and nothing was happening. And so the case got referred down to us in Philadelphia. And I was talking about this with the residents this morning at the pediatric hospital. Don't trust anybody else's pathology report. Before you do anything else, get the specimen and get another opinion from, either your pathologist or somebody that's very good. And so we did get the specimen, and it turned out that it was something quite different. In any event, when we got to see this child, this was really a worthless situation, and we were hoping that we could do something. So this was when our pathologist got to review this, it turned out to be something different. I'm sorry, and they did they did molecular genetics testing, and it turned out to be infantile fibrosarcoma. So in this situation, we had a tumor board meeting, and radiation wasn't going to work. They wanted to get rid of the tumor as much as possible, and then go with chemotherapy. So I thought, let's see what we could do. So in this situation, I tried to save the lids and the socket, because this was clearly an anterior thing. It wasn't in the posterior orbit, and if we could get rid of all the stuff anteriorly, maybe we could save the lids, because they weren't involved. But I had some problems with the lower lid vascular supply. And so we did this kind of technique, and as I said, so I wound up that her lower lid was retracted. I had to do a retrovircular skin graft, which, but at least she was retaining a prosthesis and looked, much more normal than in exoneration. And, in a child, you can't really, get a prosthetic fit externally with magnets or glue. It's very, very expensive and doesn't work very well for a child. So this just shows you the dermis fat graft survival. 16 months, that's all this white is dermis fat graft. And the black here is the shell prosthesis. And 2 years post-op. And she was treated with no recurrence and so forth, and we did some more surgery, but she needed this lower lid retraction repair. So more recently we did a SUF lift to some orbicularis oculi fascia, subperiosteal, pulling that up. And so I get these wonderful letters all the time, the holidays especially, thanking us for doing it. And she's a pretty happy child. It's a lot better than having the hole in your face. So here's another case. It'll be the last thing that I present. This is a 13-month-old child with a 3-day history of proptosis, very rapid change like this, no previous ocular medical or any other problem. And the MRI scan shows a tumor here right behind the globe. It looks like it's attached to the globe. And I thought, maybe we could get to this, in order to biopsy it. Maybe we could go take the medial rectus off and get back to that, which I did. And this turned out to be a PNET tumor, a primitive neuroectodermal tumor, which is a highly malignant tumor. And same thing, the tumor board said, no radiation, got to get this out of there, and treat it with this kind of a cocktail. So in this situation, having learned to be wise about the lids and blood supply, I was able to, that's the specimen, the tumor and so forth, the exoneration specimen, and then taking a dermis fat graft from the buttock and putting that in. And the question is always like, why is that staying and living? And I think it's because these raw edges are butting up against orbicularis that you've opened up, and because there's not enough blood supply in the bony little apertures. So then putting a clear shell in, and here she was at 3 weeks and 4 months post-op, 6 months post-op with a prosthesis. You can see the dermis fat graft is still there with the shell. Here she was 18 months, 2 years out, 3 years out, life no more complicated than any enucleation in a child. 4 years out, here she is 9 years out. So I think that in certain cases where you don't have a risk of the malignancy not being removed, when it's really anterior, this is a technique that we can use. And in summary, for what I've been trying to discuss here, is balancing function and appearance can be competing goals in our surgical reconstruction. Restoring or improving function is an obvious goal. But we should also consider how appearance impacts the emotional well-being and ability to function in our daily life, even for visually impaired. And appearance may assume an equal or sometimes even greater importance than function. So I thank you from Children's Hospital of Philadelphia. So any questions? Everyone is sufficiently stunned.
glad to meet you, doctor. It's a great lecture for us. Anybody has any question? No? Okay. It's important, doctor, the appearance and the function because when I pass in Mexico, we have I remember one case on one patient with Fraser syndrome. Fraser syndrome is a terrible problem because they have facial defects, cardiac defects, and renal defects. The family always talk with us now for neck surgery, for get a better appearance, no? But we try to do one surgery first time, no? But we don't get the better results, no? The child died 3 months ago, later, no? The case for learn, no? When we do something or not something for the child or for the family, okay? The question is that, okay, for many times we try to decide, we try the patient or try the family. What is your opinion on that?
Well, I think that's the kind of responsibility that falls on our shoulders, and I think it's harder when you're young, as a young surgeon, just starting out, because you're not as sure of yourself to get in a fight with the family, and say, I say no, And the only thing you can do in some of those circumstances to say is that you can be kind and say, I really am thinking like this is my child, and I don't want to put her through a lot of surgery and discomfort, and we're not going to get a very good result. So I don't feel comfortable for my doing that. You could go see someone else, and maybe they would have a better idea, and that's a better way to handle it. But what you don't want to do is get angry at the people, which is unfortunately something that is easy to do at the end of a long day, and you're tired, and you have a family that's very difficult and doesn't want to take no for an answer, so you have to be careful. But I think that's always a good thing to say. I don't think I have such good ideas for this situation. You could see somebody else. I can give you some names, just not your friends. I can give you the names of somebody else. But these are the tough things.
Thank you. Another question? Okay. We appreciate your lecture, doctor. We enjoyed that, and thank you for all. You are coming to Peru anytime you want. Right? We have many friends here. No? Thank you very much. Okay, thank you very much for your wife.
Okay.
And bueno, ya todos están invitados a un compartir, ¿no? Acá con el doctor, ¿no?
Well, Pedro put my wife's play up on the board here, so it's running till December 15th. It's fantastic. You can ask Fernando about it, Okay.
Fernando, algunas palabras.
I wanted to say thank you for your lecture. I really appreciate it. It's amazing. Very nice cases, very tough cases. I've learned a lot. I'm always thinking in the balance between our desire to perform surgery, or the parents desire to have surgery on their sons, and whether are there really needs of the kid. That is sometimes tough to decide. Thanks to Carl that has bring you here. Okay.
So thank you all again for the opportunity of getting to meet and know you and your beautiful city and your wonderful medical complexes. So thank you again. Bye.
Los padres